Let's begin with a quick multiple myeloma background. Multiple myeloma is a cancer of the plasma cell. When a patient is told that he or she has multiple myeloma, typically they have a very troubled look because they haven't heard the word multiple myeloma. It's not a common term, and like breast cancer, patient knows right away it's involving the breast. And when you tell the patient you have colorectal cancer, they also know it's in the colon. But when you tell a patient you have multiple myeloma, they typically will say, what is that? So it's important to begin with the very basic definition of multiple myeloma, which is a cancer of the plasma cells. It's typically preceded by MGUS, or monoclonal gammopathy of undetermined significance, or smoldering multiple myeloma. We know now that 99% of myeloma cases are preceded by MGUS and smoldering multiple myeloma. So what is the core concept in multiple myeloma? Well, in normal plasma cells, when it's not cancer myeloma cells, the job of the plasma cell is to produce antibody to fight infection. But what happens in multiple myeloma, there's a genetic switch, and that leads to a clonal proliferation of one plasma cell multiplying and replicating itself in a very fast fashion, and then they produce only one type of immunoglobulin. It could be IgG, which is about 65% of the cases. It could be IgA, which is about 20% of the cases, or it could be just the light chain, lambda or kappa light chain, which is about 5 to 10%. Very rarely, it could be that the myeloma cells will only produce IgD, IgE, or IgM, although IgM is typically associated with Waldenstrom, but there have been reports of cases of IgM myeloma as well. But these are only about less than 2% of all myeloma cases. So now let's ask Dr. Faiman about the immunological basis of patients with multiple myeloma.
Thank you. And so just so you are all aware, I'll be integrating within each of the presentations a lot of the research to kind of break it up and give you a different perspective. And so to start with that, I'd like to review what goes on in the bone marrow. So there's a complex interaction, two-way interaction between the bone marrow and the myeloma cells. The osteoclasts that nibble away at bone and help us remodel bone, and the osteoblasts that build bone don't work. We also have other chemicals and cytokines in that bone marrow environment, which makes it a little bit more challenging to treat myeloma. These cancerous cells go through a series of changes, genetic mutations and alterations until it ultimately forms cancer. So multiple myeloma is typically preceded by a non-malignant condition called monoclonal gammopathy of unknown significance, or MGUS. What is MGUS? Well, patients with MGUS have an abnormal overproduction of these cells, one clone of a normal cell, could be IgG or IgA, and they have a low percentage and no evidence of organ damage. Those individuals oftentimes succumb to other illnesses or cardiovascular disease, and they don't oftentimes need treatment. The second level is smoldering myeloma. Individuals with smoldering myeloma have a higher amount of abnormal M protein in their blood. They have a higher percentage of bone marrow plasma cells, but they still lack that end organ damage that we look for. Patients with multiple myeloma are catapulted into that category when they have signs of damage we call slim crab. These are the new criteria for diagnosis. So the patient has an abnormal protein in their blood or their urine, and we have to identify, do they have also hypercalcemia, renal insufficiency, anemia, or bone disease? That's the crab part of it. The slim part of it is an elevation in serum free light chains, capital lambda. We'll talk about the light chains in a moment. Increased bone marrow plasma cells, 60%, and then an MRI with greater than one focal lesion that's greater than 5 millimeters. It's important to find out who has myeloma requiring treatment and who doesn't, because we don't want to put the patient at risk for treatment if they don't need it. We know that there's that premalignant phase of MGUS that eventually they'll have periods of disease progression. This slide depicts the clonal nature of multiple myeloma cells. You can see when this individual had active myeloma, the clones were mostly purple. Through a series of remissions and relapses, most of their clones ultimately turned all yellow, and that means that it was typically a different clone than what they started with, and that's an important distinction. Keeping people on therapy longer will suppress those abnormal clones from forming. And we know patients are living longer than ever. In this analysis by Dr. Kumar at the Mayo Clinic, he looked at all the individuals who received newer treatments from 2000 to 2010. And what we found out is that patients have a longer 5-year survival. The analysis also showed us what to look for as nurses when we are at risk for early death within the first year. Those that are greater than age of 70 who had a lower serum albumin and a higher serum beta-2 microglobulin did not do as well for as long.
Now that you have a disease background for multiple myeloma, let's do a very quick review of the treatment background for patients with multiple myeloma. Multiple myeloma, when I started practicing back in January of 2000, the option for patients who relapsed was thalidomide. My boss, Dr. Seema Singhal, my attending physician, collaborative physician at that time, she actually published the thalidomide anti-tumor activity in the New England Journal of Medicine, and that was the only treatment available at the time of relapse. But now, fast forward, more than just a decade, we have seen an array of new classifications for patients with multiple myeloma. We have different mechanism of actions. It's a very exciting time in the field of multiple myeloma. I consider myself lucky. I was at the right time, at the right place, at a research institution for the past 15 years, and I have seen so many eureka moments with research. We started with the Mibs, the bortezomib, in 2003, that was approved by the FDA. We also have the Mibs, which are the immunomodulatory drugs, which is, we can now have the second generation and third generation IMiDs, which are now called lenalidomide and pomalidomide, respectively. We also have the Mabs now, which is the monoclonal antibody, and that starts with the approval of ilutuzumab, followed by daratumumab. And now we also have panovinostat, which is an histone deacetylase inhibitor based on the science of epigenetics. So it's really exciting to be in the myeloma field, and it is such a great therapeutic progress for patients with multiple myeloma. Let's begin with our first case, Dolores. She's a 61-year-old retired teacher, active and generally in good health, and she has a family history of heart disease. She's an active exerciser. She routinely do exercises at least 3 times a week. She has an elevated total protein that was found in her regular routine annual checkup. Her serum total protein was 10.2 grams per deciliter, and the upper limit normal for serum total protein is only 8.5. So when you subtract 10.2 with the 8.5, you know that there's an extra protein, and the next question of the clinician would be, where is that extra protein coming from? And so that would trigger the clinician to send that blood for serum protein electrophoresis, which Dr. Faiman will explain in a little bit. And then the other parameters that we've seen with Dolores, that she has a calcium of 8.5, an albumin of 3.5, which is an indication of good health, and then beta-2 microglobulin of 2.44, which is within the normal limit, which is these are all awesome number, and then creatinine of 1.1, which indicates she's got a very good normal kidney function, and a hemoglobin of 11.9, so she has no anemia, none of the feature of the CRAB for indication for any active disease. So she went in for further testing when she was referred to a hematologist.
So as Joseph mentioned, we wanted to find out how much of that protein that was elevated in Dolores's blood was abnormal protein and what kind. To do that, you order a test called SPEP, serum protein electrophoresis. You can also check the protein in the urine because protein gets spilled into the urine often, right? So this slide shows these abnormal myeloma plasma cells that are overproduced, and this Y-shaped structure is the immunoglobulin structure. The anchor is the heavy chain, which is the blue part, and that's your IgG, IgA, IgM, etc. And then the light chains are the pinky kind of structure, and those are the light chains kappa or lambda, and they can kind of fly off the structure. So some people will just have an intact M spike in their blood. You can see here albumin is the normal parameter, but if the individual has an IgA myeloma, for example, these abnormal cells will migrate to the beta region. If they have an IgG or other, those abnormal cells will migrate to the gamma region. Serum-free light chain assay analysis has been around since 2004 in the United States, and you can see again the immunoglobulin structure. These light chains are teeny tiny and toxic to the kidneys and the bone marrow, and so oftentimes patients will have bone damage and kidney damage if they have light chain type disease. A myeloma-defining event, or MDE, that meets criteria for diagnosis is an elevation of kappa to lambda free light chain ratio of greater than 100. And so that's an important distinction for Dolores. Now, as we're doing the workup, we say, okay, she has really no significant anemia, so she doesn't have the A in crab, she doesn't have high calcium, she doesn't have any creatinine abnormalities, so let's look at her bone. Let's see if she has crab features. So the historical gold standard is a skeletal survey, head-to-toe x-rays of about 20 films. Those will be sensitive to about 30 to 40% bone loss, and if you're still suspicious there's bone loss somewhere, you can order an MRI, PET scan, or other imaging. DEXA scans to estimate one's fracture risk of osteoporosis is not indicated in the baseline workup, but oftentimes patients will have bone loss found on the DEXA scans, and that'll precipitate a diagnosis. Now, there's a difference between high-risk myeloma and high-risk smoldering myeloma. We want to see if Dolores is at a high risk for progression in her smoldering myeloma, because we know she's smoldering because she's got an M protein of 3 grams. So the 2014 International Myeloma Working Group criteria say that if she has no myeloma-defining events, that's that slim crab, and if she has an elevated clonal 30 gram per deciliter protein, and clonal bone marrow plasma cells 10 to 60%, she might be high-risk smoldering, and in that case, we would consider treatment sooner than later.
So here's the final workup result for Dolores. Her SPEP is 3.2 gram per deciliter. So in the previous slide, it was the gram per liter, so that was 30. So this is 3.2 gram per deciliter. IgG lambda. 24-hour urine UPEP is 520 milligram lambda monoclonal light chain protein. The serum-free light chain assay is consistent with a lambda-free light chain of 72. Her bone marrow biopsy showed 30% lambda-restricted plasma cell. So this is really a hallmark in multiple myeloma. When you look at the bone marrow biopsy report of the patient at the time of diagnosis, make sure that the final diagnosis line says lambda restricted, or it says monoclonal lambda, because that is the pathognomonic diagnostic criteria for multiple myeloma. Because if it's polyclonal, then the patient actually don't have myeloma. It could be HIV, AIDS, and other autoimmune disease that drove the increase in the number of this abnormal protein. So make sure you look for the monoclonal or clonal or lambda restricted or kappa restricted. But for Dolores, she has IgG lambda. It will be a lambda restricted plasma cell in the bone marrow. Her cytogenetics good, 46XX, which means 23 pairs. And for women, you have 2 X chromosomes, sex chromosomes, and then her fish fluorescent in situ hybridization is normal. Her MRI and skeletal surveys negative, so that's really awesome. And her diagnosis based on the IMW, as well as based on the publication of Dr. Mateas in the New England Journal of Medicine, that if a patient has an IgG and M protein of 3 grams or higher, that patient is considered high risk, but without any of the symptoms of the crab feature, then she is smoldering multiple myeloma. So her final diagnosis is high risk smoldering multiple myeloma. So the next question is, treatment decision-making. How do we do treatment decision-making now in 2017? On the right-hand side of your slide, you will see the model of evidence-based medicine, which emphasized three major concepts: clinical experience, the clinical expertise of the clinician, the data from research that the clinician needs to share to the patient, and then the patient preference. So these three factors are a very important part in the decision-making process. For Dolores, there is clearly an option, and shared decision-making is the appropriate and I would say the ideal model of delivery of care, because she has the option for watchful waiting as well as clinical trial. There's also important considerations such as lifestyle and quality of life that depends on the type of treatment, intravenous, oral, subcutaneous, and that may require a change in her schedule of work if the patient needs to go to the clinic more often than what's required. In oral therapy, then the patient can only be seen every 4 weeks, and then they just get their refills. So there are those quality of life and lifestyle issues that need to be considered. A second opinion is also very critical so that Dolores will get the information from a myeloma specialist to help her make that best decision for herself.
So as we mentioned, it's really important to have that shared decision-making process. We'll go a little bit more into that in just a moment. But how does she decide on whether or not to do clinical trials? It's not recommended to start treatment right now for Dolores, so she must consider a clinical trial if we want to recommend some treatment to delay her progression. Basically, phase 1 and 2 clinical trials are a smaller sample. We're trying to determine effectiveness of a compound in a variety of cancers, and then sometimes a specific. Phase 3 are larger randomized trials, and those are very well designed to compare one standard to another. The IMF, International Myeloma Foundation, has a wonderful myeloma matrix which lists all the clinical trials by stage, disease, and geographic location, so we should refer her to that resource.
So a very quick review of what is shared decision-making. Shared decision-making has 4 essential components. The first one is that there's 2 participants, the healthcare provider and the patient. Number 2, there should be both parties should exchange information. And number 3, both parties take the steps to build consensus about the preferred treatment. Now, in shared decision-making, steps 1, 2, and 3 are very easy to achieve. I think we do it already naturally, but it's always the step 4 of shared decision-making that is not well executed in practice. Because in step 4, there should be an explicit mutual agreement that has been reached between the patient and the caregiver on what the treatment should be. And that the patient should explicitly say the preference. And this is sometimes not happening. It's more about implicit instead of being explicitly drawing the patient's decision in terms of treatment. In the era of new shared decision-making, we wonder, how did we get here? Well, what we know is that in the early 60s, after the World War II, our parents, grandparents, when they go to the clinic and they're diagnosed with cancer, they would say, "You're the doctor, you make the treatment decision for me." Well, there's slow shift in that paradigm of paternalistic delivery of healthcare because of the increasing cost of healthcare cost that is now being shouldered by the patient, and patients are starting to say, if I am paying a lot of money, I should have a say about what my care should be. Given also the rise in healthcare consumerism in the United States, Canada, Australia, and the UK, these are the driving forces that shifted us from paternalistic to shared decision-making, which is all about patient-centered care. There are many short-term benefits, as you can see there. I will name 2: increased confidence with treatment decision, higher satisfaction with treatment decisions, and then the long-term is really the nicest one. It leads to treatment adherence, better quality of life, and because the patient adhere to the treatment because they are the stakeholder and you got their buy-in from the very beginning, they have a say. So they're vested on the treatment to be successful. It leads to improved overall survival, improved progression-free survival because of better treatment adherence. The role of the nurse are multifaceted in shared decision-making. Our primary role is patient education. We are the most trusted professional source of information according to my study in multiple myeloma patients as part of my dissertation. We also assess, monitor, and make sure we manage the side effects of chemotherapy. We provide psychological support during the treatment decision-making, sitting next to the patient, listening to the patient, be present is already an amazing psychological support that we provide to our patient. We advocate for the patient all the time. We always emphasize autonomy, and we always advocate for the patient, and we always say, do what's best, what you think is best for you. And that is our respect for patient self-determination. We also perform outcome evaluation and coordination of the multidisciplinary care that the patient is receiving. Going back to Dolores, she decided to enter into clinical trial, the NCI trial, which is lenalidomide or observation. It's an NCI phase 3 trial. And then she qualifies because she has no symptoms that is part of the CRAB criteria. So she has no end organ damage. So that's how our case study ended.